I'd like to introduce you, if you haven't already met him, Dr. Matthew DrEschelbach. He is our Assistant Medical Director, and he hails from Redmond, Oregon. He is a medical director there for EMS and trauma at St. Charles Medical Center, and at least one, if not more, EMS services there, Doc?
Oh, about 10.
There you go. So he stays pretty busy and is a firm believer in what you can do. And it's just really is bad that I'm not going to keep the power, because I always enjoy listening to these lectures. But fortunately, I'll hopefully be able to extract it and put it into the MD Roundtable and watch it later. Again, if you would, and I see Dalton just came on, if anybody else comes on after I disappear, make sure somebody gives them a side message and tell them that they need to email me and let me know they were here. And again, I'm trusting you all to stay if I disappear for the whole session, so you can get your credit. So that having been said, Dr. DrEschelbach, I'm going to turn this over to you.
Very good. Thank you, everybody. If Jane does have to pop off because of the power, I'm not always great at seeing questions on the right-hand side. So unmute your microphone and ask a question if you want to, and then remute, because I think it eats up bandwidth, I think. And the other is, at the end of we'll have questions. So if I don't get to your question or I don't see your question, we'll get it at the end. We're going to talk about toxicology. This area of emergency medicine is actually a specialty. It's not one of my specialties, but it's one of my favorites, because I love to try and figure things out. The other word for this is toxidromes, kind of like syndrome, but toxidromes. And that's the way I want you to think about these. Is we may not be able to figure out exactly what the poison is, but if we look at the signs and symptoms and see what we're looking at, we might be able to figure out what the person took. Ultimately, that's not necessarily your job. However, it is your job when you see something that's obvious and you're trying to put two and two together. And I'll talk about those real specific ones, the ones you can't miss. But toxicology can be kind of fun. It's an actual fellowship. So if you were to go to, let's say, Oregon Health Sciences University, the medical school here, the medical school here is actually the poison control center for several different states. So you'll get to speak to a toxicologist who's on call. And I used to want to, early in my career, want to memorize everything, and didn't want to ask for help. And then the older I got, I don't mind asking for help. In fact, even if I'm absolutely certain of what I'm doing, I call a toxicologist just to make sure that I'm not missing something, because you don't want to hurt the patient. So as you're going through this, there's a lot of information to swallow. Don't be inundated with the minutia, because this isn't a medical school lecture. If I was giving this to medical students, I would make them memorize some of the minutia. But I don't think it's important for most physicians in general, and certainly not EMS, to memorize the specifics. What I want you to do is memorize the whole approach to toxicology. So that being said, we'll move away. We'll go on. So why do I love emergency medicine? I'm not that smart, but I'm usually smarter than a lot of my patients. So we'll talk about toxidromes. Most of these are overdoses, some intentional, some not intentional. Some are very timely, meaning we'll see them, and some we'll see every day. And for some of you, you're not going to want to see them every day. And some we'll see very rarely, but we have to know how to save a life. So we'll just talk a little bit about pharmacology, everybody's favorite subject. There are tens of thousands of drugs and tens of thousands of classes of drugs, and you can never hope to know every one of them. Even if you're a toxicologist or a specialist, which is like I said, 2 more years after you finish your residency, it's a specialty that just constantly changes. But what's remarkable about all of these thousands of drugs is sometimes you can break them down into very few dangerous toxidromes. For example, things that will kill you, there are 1 pills that'll kill you, or a child, for example. Like for a child, 1 sulfonylurea, or an oral insulin diabetes medicine, not insulin, but an oral diabetes medicine, can kill a child. 1 beta blocker can kill a child. But most people, if they take an overdose of ibuprofen, will just get an upset stomach. Aspirin, however, can kill you. Tylenol can kill you. So these are the things that we try and fit into toxidromes. We're not going to talk about aspirin today. We're not going to talk about Tylenol today, but we're going to talk about some of the others that fit into a general category. By understanding the toxidromes and the side effects that present, we can kind of take a look at what am I seeing in front of me, what is the patient presenting with, and how do I go over that. There are 7 major toxidromes and a few minor ones that we'll cover today. As I move through these quickly, keep in mind that if I gloss over a slide, it's not that it's not important, it's just I don't expect you to memorize that, just understand the concept. And you can always come back and watch it later. What are the major ones? Anticholinergic drugs, we'll talk about those. Acetylcholinesterase inhibition, extrapyramidal drugs, hemoglobinopathies, narcotics, sympathetic, sympathomimetic, and withdrawal. So some of you are probably going, oh, I recognize 2 of those, all right? But as we go forward, you'll see you probably recognize a whole lot more. So don't be, like I said, freaked out about all these big words. This isn't a test, but you're going to see that they fall into very common drugs. And some of these very common drugs our patients will take, and I'll talk about those. So let's talk about potions and poisons. Here we go. Here's a little trick, a little cartoon for you. So here's this little guy selling the ice drink for 5 cents, and around the corner, his buddy's getting $1 for the antidote. So what does that mean? Why do I show this cartoon? Well, it's because of this guy, Paracelsus, way back in the early 1400s, early 1500s. He said, all substances are poison. There is none that is not a poison. The right dose differentiates a poison and a remedy. So we'll talk about Tylenol very briefly. 2 extra strength Tylenol might take away your headache. 200 Tylenol will kill your liver. 3 aspirin or 1 aspirin might help you for your circulation. A bottle of aspirin can kill you. So all substances are poisons to a certain amount. It's just how much do we take and what's the right dose. So what is a dose? It's the amount of the chemical entering the body. It's usually given in milligrams of chemical per kilogram body weight. That's the scientific way. You could do it ounces per pound if you were so inclined, but scientifically it's milligrams per kilogram. The dose is dependent upon the environmental concentration, the properties of the toxicant, whether it's in liquid, solid, or something you inhale, the frequency of exposure, the length of exposure, and the exposure pathway. So keep in mind some of these variables of dose when we talk about ways of overdoing something. For example, if you were in a room with carbon monoxide poisoning, the length of exposure could be with a high concentration, very brief. You could pass out from not having enough oxygen, or it could slowly kill you overnight if you've got a faulty furnace. So what is a response? Meaning, what does the body do? And the degree of and the spectra of responses depend on the dose and the organism. And that means, are you a child or an adult. So what might be dangerous for a child, like I said, 1 or 2 pills can kill, would be different for an adult. You change from normal state, meaning is there something going on in the body? Is there a disease in the body and people aren't getting enough oxygen to begin with? So somebody who has COPD might be a whole lot more susceptible than you or I to an inhaled toxin. Local reactions versus systemic reactions, we'll talk about those. Are they reversible? Let's go back to the kid selling lemonade. If he sells the lemonade and his friend around the corner sells the antidote, is there an antidote? Every day we use Narcan, which is a reversible antidote for narcotic overdose. Most of the toxidromes we'll talk about today have an antidote, and that's what is important for you to recognize. Is immediate or delayed? Well, another example, I have to keep going back to Tylenol, but if you take 200 Tylenol, you're not going to see the effects right away. Hopefully your body would see it and vomit it and get rid of it, but if it didn't, it would be maybe 3 days before the symptoms appeared. And then by that time, it's usually too late. Graded versus complete, that means is it a complete exposure or is the exposure all or none? Degrees of the same damage versus all or none. So this is a dose response curve. This is, the dose is the bottom line and the response is the y-axis. So if you look at this, you can see that every drug intoxicant will increase and they all pretty much have this same simple curve to them. No response, a linear range, and then a maximum response where all of the receptors are taken, and I'll talk about those in a few minutes. The dose determines the biological response. So over time, the response depends usually on the dose. The higher the dose, the greater the response. Why is it not a straight line? Because the biomechanics of availability of the medication make it this curved S. So first thing you have to understand is something called the lethal dose 50 or LD50. So LD50 is the median lethal dose, abbreviation for lethal dose, or the concentration where half the people will get sick and half will not. It's the time and concentration of a toxin, whether it's radiation or pathogen or a dose of a medication, required to kill half the members of a tested population after a specific test duration. That sounds kind of evil, but what that means is, let's say we're talking about gamma radiation. How much radiation would kill half the population? Or how many milligrams of narcotic will make half the people stop breathing? Or how many milligrams of Benadryl will cause people to die? So that's the lethal dose 50 is an average. And sometimes we talk about LD50 specifically, but most of the time it's just there as a published number. So here's a couple of examples of LD50s. And when you talk about milligrams per kilogram, that's going back to the dosage we talked about a few minutes ago in response. What is a dose? Milligram per kilogram. All right, so good news. It takes a lot more ethyl alcohol to kill you than botulism, okay? But here's the bad news. Botulism toxin, which is probably the most potent toxin known to man, it takes micrograms, very, very small amounts, to kill a person. So as we go down this chart, you can see things like sodium chloride, milligrams per kilogram. It takes an awful lot of salt to kill you, even though I suppose you could probably a couple of salted bagels might do this to you. Iron ferrous sulfate, morphine, for example, which is the equivalent for narcotics, strychnine, nicotine. Doesn't take much nicotine to kill you, but the concentration of nicotine is not that high in cigarettes. Black widow, curare. Curare is the precursor to succinylcholine, something we use every day to put somebody to sleep when we intubate them. Curare was the one that was discovered by the Indians in South America. A rattlesnake, dioxin, which is a poison, and then botulism. So you can see certain things take a lot and certain things take very little. All right, we'll talk very quickly about drug pathways. No matter what the drug is, they all follow the same pathway. Each one has a receptor, and each one has a natural chemical that fits inside the receptor. There are two types of drugs, something called an agonist drug or an antagonist drug. An agonist drug sits in the receptor and will draw in more of the natural chemical. One perfect example of this is something we call a beta agonist. Something that we give every day to patients who are wheezing is albuterol. Albuterol is a beta agonist, and it opens up the pathway. Compare that with something like a beta blocker to slow down a heart rate. A blocking drug or an antagonistic drug sits inside the receptor site, plugs it so that the natural chemical can't hit. So let's say that natural chemical in a beta blocker is something like epinephrine or adrenaline. The beta blocker sits in there, adrenaline comes along, and it bounces off, it can't bind, and therefore the heart can't speed up. As opposed to the agonist drug, like the terbutaline or something like Ventolin, sits in there and asks the guys to come in more and will open up the airways. So even though they both hit beta, one's a beta 1, one's a beta 2, these are beta 2 and these are beta 1 if we're talking about beta blockers. So that's how all drugs work. No matter what it is, they either naturally occur, will enhance it, or enhance it like an agonist, or block it like an agonist. How does it work at the cellular level is every nerve has receptors. For a pathway to be complete, a nerve receives a signal, and then the neurotransmitter is released and it goes to the other nerve cell and it's recepted. Whether it's a heart cell or a nerve cell or a muscle cell, most neural cells, that mean where nerves transmit some type of signal, work this way. It's released on one side and received on the other side, and then this cell does what it's supposed to do. Neurotransmitters, things that are specific for nerves, are released into the synapse of the cell and receive the chemical signal. The cell that generates the signal is called the presynaptic cell, that's here on the left, while the receiving cell is the postsynaptic cell. All right, so here's the first of our toxidromes. Why do I show this picture of Lewis Carroll and Alice in Wonderland? It's because of this guy right here, the Mad Hatter. Why was he mad? Well, he apparently, hatters back in England, worked with mercury. We're not really talking about mercury, but you will hear the term in anticholinergic poisoning, mad as a hatter. So, anticholinergic poisoning is perhaps the most famous of the toxidromes, and probably the best understood. The effects of this syndrome mimic an overdose of atropine. Now, you use atropine every day when you're trying to speed somebody's heart up, right? That's a perfect example of something that we use as a drug, which can also be a poison. So the effects of this syndrome mimic atropine, and drugs we use daily to save lives from patients from hypoperfusion. So somebody has a heart rate of 40, and they're showing signs and symptoms of not having a good blood pressure. You want to increase the heart rate, you give them a milligram of atropine or a half a milligram of atropine, right? And that helps them. The wide variety of drugs presented to the elderly, for example, makes a specific target for this syndrome. And you can get a type of delirium that's often misdiagnosed or missed entirely. So what that means is that sometimes patients take too much of their regular medications, and things like antidepressants or anti-Parkinson's syndrome medicines or antihistamines, even over the counter, can cause this anticholinergic syndrome. A perfect example is a little old lady who takes a Benadryl because she's got congestion, and it doesn't work, and she takes another Benadryl, and she takes another Benadryl, and before you know it, she can wind up with an anticholinergic poisoning. Acetylcholine is a major receptor that we talked about in the former slide. The body's responsible for transmitting a nerve impulse from one to another, and acetylcholine is the major neurotransmitter. When acetylcholine is blocked or inhibited in excess, a syndrome known as anticholinergic syndrome is created. So here's a very busy slide. I'm just going to go over the basics, but here's a nerve cell, here's a nerve cell, here's a nerve cell, and certain ones are supposed to hit the receptor, and other ones can block the receptor. I'll talk about this in just a few seconds, but if you look at acetylcholine over here, this is acetylcholine, and then something comes in here and blocks it, and it bounces away. All right, anticholinergic poisoning, central effects can be agitation, amnesia, anxiety, confusion, circulatory collapse, lethargy, respiratory collapse, seizure, disorientation, difficulty with speech, hallucinations, coma, delirium, and visual disturbances, to name a few. Peripheral effects, you can have arrhythmias in the heart, tachycardia, decreased bronchial secretions, difficulty swallowing, decreased GI motility or constipation, hyperthermia, hypotension, low blood pressure, hypertension, decreased salivation, decreased sweating, and urinary retention, meaning you can't pee. So as you look at this big long list, you're going to see a very, very common syndrome come up in a slide or two. So anticholinergic poisoning, the cardiac manifestations is sometimes you'll see, including in especially tricyclic antidepressant overdoses, you're going to see a widening of the QRS and conduction blocks. I'll come back to that in just a few minutes. So it can affect the heart. So here's your mnemonic. This is what you need to remember. Here's our Mad Hatter over here, and the anticholinergic poisoning syndrome mnemonic that you're going to see, and you need to remember because I'll go over that. Mad as a Hatter, that's the confusion or disorientation. Dry as a bone, remember they couldn't sweat and they got hyperthermic. Blind as a bat, that's because their eyes dilate and they can't see. Hot as a hare, That has to do with not being able to sweat. And red as a beet, same thing. They can't sweat and they get red. So you go back to this and you look for these symptoms: decreased sweating, decreased salivation, dry as a bone, hyperthermia, hot as a hair, all right, difficulty swallowing or agitation, anxiety. That's the mad as a hatter. Manifestations: you're going to get dry skin and thirst, fixed and dilated pupils. That's why you can't see, you're blind as a bat. Tachycardia, hot as a hair, hyperthermia, confusion, seizures, and hallucinations. That's your mad as a hatter. Your dry skin is red as a beet. Okay? Causes: atropine or atropine-like drugs. Most of us don't take atropine, and most of us wouldn't want to take atropine, but there's certain things like belladonna, certain mushrooms, very commonly antihistamines like Benadryl, and tricyclic antidepressants, still used by a lot of people to fall asleep at night. Most of the time, antidepressants are of the Prozac variety, and they're a different type of antidepressant. They affect serotonin in the brain, but the older tricyclic antidepressants are still used a lot by people who like to sleep at night. A partial list of substances: antihistamines, Benadryl and Claritin, both can do that. Antivert is over the counter for motion sickness. Anti-Parkinson drugs like Cogentin, antipsychotic drugs like Thorazine, antispasmodic drugs like Bentyl, which people use for irritable bowel syndrome, plants like mushrooms, antidepressants such as Elavil, sometimes ophthalmic drugs. Old people have glaucoma and they'll use different ophthalmic drugs that can go into the circulation, and over-the-counter medications such as Benadryl, and muscle relaxants can also cause this. Here's some over-the-counter medications: Excedrin PM, Actifed, sleep aids like your Benadryl PM, Sleep Ease, Sominex, they all contain Benadryl. Dramamine, which is an anti-nausea medicine and also one for motion sickness. Benadryl, Claritin, Antivert is one that's used over the counter for dizziness, and Pamprin, which is used for menstrual cramps. All right, now we're going to go into, so that's it for anticholinergic. Anticholinergic mushroom poisoning. Sorry, that's another type of poisoning. These mushrooms contain amatoxins, and the symptoms usually become 8 to 12 hours, even longer after the mushroom is eaten, and death can follow in 2 to 3 days. This is slightly different than those toxins that affect the liver, like poisonous mushrooms is a different type of poison that kills the liver. And usually treatment is supportive after the mushrooms have been cleansed from the GI tract. Belladonna or nightshade is used by some kids who want to get high, as well as Jimson weed is also used by people who go out into the desert. Some people use it as a homeopathic remedy. Keep in mind that all of the side effects of a medication might be something that somebody wants to put in their body to combat another symptom. So if somebody's having a problem with loose stools, they might have some type of Jimson weed out there as something that's going to help constipate them. But Jimson weed is very frequently also smoked by people who think that it's going to get them high. Treatment protocols, usually it's just conservative treatment is the mainstay. ABCs of basic life support, try and calm and reassure the patient that eventually these things usually wear off, but sometimes just being a detective and finding out what's going on. So you get called to a home of an elderly lady who's got a fever. She's acting odd. She's somewhat delirious. And you figure, old lady, fever, urinary tract infection, sepsis, pneumonia, but maybe it's just the Benadryl she's been taking. When I took my oral boards for emergency medicine, one of the cases they threw at me was a lady who presented just like that, but her urinalysis was clear and her CAT scan was normal. And I had to go back and ask the EMT, it's a play actor when you're taking oral boards, what other medications were in the room? And he handed me a bottle of Benadryl that she's been taking for a cold. Otherwise, it would have failed the test. So IV fluids, oxygen, document temperature when necessary. You can get seizures, so you can treat it with Ativan, Valium, or midazolam. And activated charcoal may be of some benefit, but most of us are shying away from charcoal because it's just not used as much. Agents' comments on GI decontamination. That's one way of doing things. Activated charcoal may be helpful to help absorb the toxin. Sedation sometimes with benzos will decrease the risk of hyperthermia. Rhabdomyolysis is when people break down muscle tissue that can cause kidney failure and traumatic injuries. Sometimes a wide complex tachyarrhythmia can be seen, and a simple treatment is sodium bicarbonate. I think I have an EKG here to show you in just a minute. Cholinesterase inhibition with physostigmine is done in the ER, so that's not really going to be something that you do. Avoid phenocyanthines. Those are the ones like Phenergan and Compazine. Most of us have shied away from those entirely because they can cause worsening side effects. They can actually cause more problems. Physostigmine is reversible, and it's given in the ER in extreme cases. Most people don't use physostigmine that often. So here's the EKG I wanted to show you. See the wide QRS? So let's say you're a great paramedic and you're called to the scene, and old lady that we talked about who's acting weird, and you think maybe she's septic, she has a fever, and you go through her medications, you grab them off the nightstand, and you do an EKG, and this is what you see. You see this widened QRS. Well, maybe she's taking Elavil to sleep at night, and she had too many. Sodium bicarbonate is a simple treatment. In our protocols, we have sodium bicarbonate in those type of tricyclic antidepressant overdoses, but it's usually with medical control. All right, we're going to move on to the next one, acetylcholinesterase. That's a big fancy word. I'll never see that. But what do I see? I show you here. I show you a farm scene. The first time I ever took care of a true acetylcholinesterase overdose was in a farm community about 40 miles from here. What happened was this guy was out in the field picking carrots. They grow carrots in the field, and they actually grow carrot seeds. And he was tending to the crop and fixing the water line when overhead somebody came in, and with a crop dusting plane, they sprayed poison on top of him, and he wound up in an acetylcholinesterase toxidrome. I saved his life, but it took a while to figure out. The other thing that you might see, you may have seen this old-fashioned movie, The Rock. It's not that old, but is Sean Connery, Nicolas Cage. And the story is this guy, Ed Harris, was a general who got a hold of some chemical weapons, and he was going to shoot it from Alcatraz into the city of San Francisco and kill everybody. And they were going to hold the United States hostage. And Nicolas Cage and Sean Connery had to save them. Old movie, but a good one for chemical warfare. And you say, well, wait a minute, that's Hollywood. But not that long ago, in 1995, the Aum Shinrikyo cult, a Japanese Buddhist group who deployed sarin, used sarin in a Tokyo subway station, causing 12 people to die and more than 5,000 people injured. And if you think about that, we know that every week somebody's doing something stupid in a terrorist attack. This is one of the most likely mass casualty EMS possibilities. So this is one you're going to have to recognize. Of course, in the Gulf War, it was proven, the first Gulf War, that this gentleman, Saddam Hussein, actually used chemical weapons in 1996, and 20,000 American troops may have been exposed to sarin, which is a toxic nerve gas. In 1997, the CIA suggested the deadly gas may have spread further than previously thought, affecting perhaps hundreds and thousands of troops in small amounts. Ricin, which is a weed, you can use ricin. It was in the news recently that somebody used ricin and put it in an envelope. Now, to make chemical weapon, you really have to refine this. It's not something that can be done in a bathtub, but it is something that somebody who has a basic college degree, like all you guys took chemistry, if you follow chemistry, if you can make certain chemicals in chemistry, you could make ricin probably as well. This is the most likely source. I'm showing you here. This is an old-fashioned biplane, but organophosphates are still frequently used. Organophosphates are used in the powders that you spray on your roses, and also used in the crops that we protect and try and kill bugs. What's the pathway? You've already seen this one. Organophosphates form a reversible bond with cholinesterase. So I go back to this neurotransmitter, and they a reversible bond with cholinesterase, one of the most important enzymes in the breakdown of acetylcholine, which we just talked about in the prior syndrome. So the binding of organophosphate to the cholinesterase leads to too much acetylcholine, and this is called a cholinergic crisis. So think back of our last toxidrome, the Mad as a Hatter. This is the direct opposite. It leads to an interference of the central nervous system. I'll show you in just a minute. So these are the type of effects that we see. Muscarinic refers to the type of receptor. Don't worry about that. But you can see pinpoint pupils, blurred vision because of the pinpoint pupils, nausea, vomiting, diarrhea, salivation, meaning you're too much spit, lacrimation, you're crying too much, a slow heartbeat, cramping, you break out in a sweat, wheezing, urinary incontinence, and fecal incontinence. Think of our last slide. These signs and symptoms are almost 180 degrees opposite. You can also get, these are nicotinic effects. These are the ones that affect the muscles. You can get paralysis, muscle weakness, tachycardia, and pallor. Centrally, you can get unconsciousness and confusion. You can get crazy psychosis. You can get seizures, fatigue, respiratory depression. Ataxia means you can't walk right. Dysarthria means you can't talk right. and anxiety means that you get anxious. Now you're going to go, wait a minute, Dr. Eschelbach, I'm confused. In the last slide, you said confusion, and it's in this one. Well, that's the fun thing about toxicology, because a lot of these things you're going to see have very similar effects. But the major ones we'll talk about in just a minute. So what kinds of poisoning can cause this? This is the organophosphates we talked about, insecticides, parathion, diazinon, orthene. I went to school in the Midwest. I didn't know what these were until I turned on the TV, and you're probably going to see these on the TV at night if you live in the Midwest and there's crops. Chemical weapons, we already talked about, and bioterrorist weapons, we already talked about. So, exhibit your symptoms. What are the symptoms of anticholinesterase physiology? And it's this syndrome. So, last time we talked about Mad as a Hatter. This is the one you have to remember here. Sludge syndrome. Salvation. That means not having your soul saved, but too much spittle in your mouth. Lacrimation, too much water in your eyes. Urinary incontinence, diarrhea, GI distress, and emesis. So sludge syndrome, essentially, you're drowning to death. Drowning to death. Look for an agitated comatose patient in sludge syndrome, drowning in their own secretions. Sometimes you'll have a petroleum or garlic-like odor. That garlic-like odor, when I talked to you early on about the gentleman who was out in the field, he was found unconscious. We didn't know why he was acting the way he was doing until we started to cut his clothes off and he smelled like a bad cheeseburger. That garlic-like odor was the key to figuring out why he had an overdose. Or did he have a history of exposure? Is he a farm worker, gardener? And obviously, if you're in war and you're a soldier, you're going to think of this. What's the management? First, protect the staff, meaning if you're cutting clothes off, make sure that the staff is protected, that they wear protective clothing. So just like a decontamination scene and a hazmat scene, you're going to have to protect yourself and protect the staff. Barrier precautions externally, meaning wear gloves and eye protection. External decontamination, you're going to have to call in hazmat and spray them down. Adequate ventilation, meaning there's not anything in the air, and you can have some violent behavior and exclude at-risk staff. What does that mean? If you're pregnant or you have a colleague who's pregnant, they need to be away from this because this can harm the fetus as well. So you have to be careful in this scenario. Decontamination, ABCs. Sometimes you have to intubate these people because remember, they're drowning in their own secretions. You have to be careful because succinylcholine may have a prolonged effect because of the side effects of the drug, pseudocholinesterase. Just keep in mind that you got to be careful when you intubate these people. You want to get your airway in. You don't want to miss, because if you give somebody succinylcholine to do RSI, you don't want to miss that airway. Lots of suction, 2 IV lines. And here's the great thing. In our last syndrome, too much atropine-like drug caused the problem. In sludge syndrome, atropine is the solution. The problem with atropine is these people need 2 milligrams every 5 to 15 minutes. Now, if you're taking care of 1 organophosphate patient or 2, think of your atropine. How many of those do you have in your kit? How many are in the hospital? Not that many. Sometimes if you have to do this, the hospital may wind up calling paramedics saying, we need some of your atropine. Or you might have to call another hospital in the area saying, we've got an overdose victim, we need atropine. One poison patient can wipe out an entire supply. There's an area here in Oregon where we used to keep, prior to getting rid of them, organophosphate or sarin-like drugs. They had tons of atropine. Tupam is also something that reverses it. It has to be given in the first 24 to 36 hours. And it's a medical controlled drug, 1 gram over 15 to 30 minutes. If you're a soldier, you've got two things on your arm. You've got atropine self-injection and Tupam self-injection. And those are two things that'll save your life. And most soldiers now have them right on their left arm. All right, moving on to extrapyramidal syndrome. Why do I say extrapyramidal? Look at the pyramids. Pyramidal is an area of the brain that's affected. Extrapyramidal syndrome, just like anything else, goes along the pyramidal track. That's where the symptom came from. It's a constellation of symptoms that are produced by a number of commonly prescribed medications. Here's our friend Parkinson-like drugs. You can get symptoms like a Parkinson patient, loss of muscular control, profound weakness, and rigidity. If anyone's ever seen this movie about the very beginning of it's called Awakenings. It starred Robin Williams and Robert De Niro, and it showed how Robin Williams used something called dopamine to cure somebody who had what was called a sleeping sickness type of syndrome. Actually cured a patient. Eventually, too much dopamine was given and it was reversed. But that's one example of extrapyramidal syndrome. Neuroleptics or extrapyramidal drugs act by blocking dopamine receptors, adrenergic receptors, those are the ones that respond to adrenaline, muscarinic receptors, those are the ones in your muscle, histamine receptors, you know what those are, and dopamine 2 reception is also blocked. Haldol is one of the medicines that you give for somebody who has an agitation. Most of you probably have some type of coma cocktail, meaning some people will not call it a B52, where you give Benadryl and Haldol and Ativan to a patient, or some type of benzo to a patient to stop them from being aggressive. It's one of the most famous neuroleptic medications. It's commonly used. Drugs such as Phenergan, which we don't give as much in EMS anymore, but it's still prescribed as an anti-nausea medicine. So is Compazine to stop vomiting because it works in the brain. I showed you that first thing about the brain. It blocks the center of the brain that's responsible for vomiting in the medulla. Symptoms of extrapyramidal, you can get a Parkinsonian crisis. That's terrible rolling of the hands. You're unable to speak. Your muscles can get rigid. Trismus means they speak in a very high voice that almost sounds like a squeak. So I'm going to do it myself. I'm not an actor, but they talk in a voice way up here and they can't talk correctly. They can get tremor. Torticollis is a wry neck, or they get a spasm in the neck. Some of them, this trismus is so bad that they just shriek, or they can't talk at all and they have laryngospasm. So some of the other manifestations, the history and physical is most important. Let's say they're moving their hands all around like this lady is, and she can't see what's going on. You'll see that this old picture of differential diagnosis has drug effects. the drug effects from things like Haldol, anti-nausea medication, antipsychotic medication, and some recreational drugs. Recognition, just like the other two toxidromes, is the mainstay. Supportive care, ABCs, IV establishment, and here's the great thing. Benadryl is the treatment. So remember our very first toxidrome, Benadryl can cause it. Here we are in our third toxidrome, and Benadryl is a treatment. When did we see this? We saw this when we gave Haldol and people started to get these crazy symptoms that we talked about here and here. And the treatment, people would call in and say, he's acting really weird. And I said, what medicines did you give him? Haldol. All right, give him some Benadryl. You all carry Benadryl, and it's easy to give. All right, hitting the home stretch, a few more. Hemoglobinopathies, very important. Not all of you are going to be EMTs all of your life. Some of you, if you work in rural areas, will be not only EMTs, but you'll have to be firemen. So you're going to have to do this. We'll talk about that later. And I'm interested in how many of you actually have to be firemen as well. Here in Central Oregon, in a more rural area, most all of our EMTs are also firemen. They have to do both. Seattle, big city, you got a choice. You can be a fireman or you can be an EMT paramedic. Most all firemen are at least EMT basics. All right, hemoglobinopathies, a big wide category for any toxic gas that binds to hemoglobin. Those are the red blood cells, and cause a deficiency in the body's ability to give you oxygen. That's what a hemoglobinopathy is. So oxygen's life, right? You got to know the equipment. No matter how much your equipment's working, if you're not getting the oxygen like this guy is, you got to know what's going on. So air is life, and oxygen is life, and it's crucial for all of your metabolism. Carbon monoxide is probably the most common hemoglobinopathy that you're going to find. It's the single leading cause of toxin-related death in the United States. Carbon monoxide is colorless, it has no smell, and it's non-irritating, which means that you can sleep in it just fine. Specific gravity is 0.97, therefore it doesn't really stratify or separate. It just kind of sits there. And then it has affinity for red blood cells. That's 210 times that of oxygen. So we go back to this thing. Carbon monoxide binds to these little red blood cells, and the bond between carbon monoxide is 210 times stronger than oxygen. That means you can die pretty quickly. So it's produced by the incomplete combustion of fuels like gas-powered engines, poorly maintained heaters and furnaces, wood stoves, kerosene heaters, indoor charcoal fires, and sterno fuel. Direct binding to the hemoglobin, meaning it binds directly to the red blood cell, and it shifts the oxygen hemoglobin dissociation curve, meaning the ability for the oxygen to come off and go to your cells. It binds myoglobin, meaning in your muscles. It also binds up, especially cardiac muscles. That's why you can die. And it inhibits cellular respiration. That means your mitochondria don't work. And in your brain, you can wind up with neuronal damage. So it's a bad player. Often it's very vague symptoms. Very often we'll misdiagnose somebody. They'll come into the ER. It sounds like the flu. And while they're in the emergency department, they get better because we might put them on oxygen or they're breathing fresh air. And then they go home, back to the bad heater, and their symptoms come back. Epidemic occurrences can happen in families. You have a bad heater and the whole family can get sick. So you have to really think about it when somebody comes in and they talk about the flu and they're not feeling good and everybody else has the flu. But if you're a good detective, you might find out that they all have a bad car. There's a hole in the bottom of the car, and carbon monoxide's coming out of that. Headache, nausea, vomiting, and dizziness, pretty nondescript symptoms. Shortness of breath, seizures, coma, and death can follow if it's not detected. They can't think well, and they have visual disturbances, and they might have chest pain and palpitations. Signs and symptoms increase as the carbon monoxide goes up. So at percentage, first they might get a headache, then they might get a throbbing headache and shortness of breath. At 30 parts per million, they're going to get nausea, confusion, coma, and eventually death. This is what happens when a whole family can die if there's a bad heater in the house and it's not serviced well, or if somebody is trying to heat inside the house with like a camping heater that's used for outside. Prevention assumes that those potential victims take precautions to prevent exposure to the gas, right? So you're going to need proper ventilation, proper performance of equipment, and avoidance. Sometimes I'll diagnose this in the ER when I see one or two people who are sick and they're out camping. Let's say they have a camper and they're hunting for the hunting season, and they go out and the camper hasn't been properly serviced, and they don't have a carbon monoxide detector, and everybody in the camper comes in with the flu, and they blame it on something they ate last night, and really it's bad circulation from a bad or faulty heater. Treatment is real easy. Remove the victims from the area, put them on a cardiac monitor, high flow oxygen. The half-life of carbon monoxide is about 320 minutes, and that means in room air, and 50 to 80 minutes on 100% oxygen. So the treatment's easy. You put them on high flow oxygen. Sometimes we have to use hyperbaric oxygen, put them in a hyperbaric chamber with severe cases, or if somebody's pregnant. If somebody's pregnant and I diagnose carbon monoxide treatment, I usually transfer them to a chamber where they can get hyperbaric oxygen. All right, narcotic overdose. Why do I show Sleeping Beauty? Because I'm convinced that the apple that they gave Snow White was probably loaded with fentanyl. All right, narcotic use, we know about this. It's big in the news, the opioid epidemic. There's legal narcotics that control pain, and there's acute and chronic pain, and it's a large problem. Legal narcotics are also abused. Multiple physicians, people go to multiple physicians, or they have chronic pain and they're put on opioids. And the thing about narcotics is you have one and they work, you have two and they work a little bit more, and eventually it wears off faster and faster, and the body gets used to the narcotics and too much, and they wind up in overdose. Methadone is enjoying a legitimate resurgence for treating chronic pain, but it's also a problem with opioid overdose. It comes from the poppy plant of opium. Heroin, morphine, and codeine all owe their origins to opium. Narcotic derivatives, heroin, of course, we don't use or prescribe, but there's morphine, methadone, a lot of people on that, codeine. Demerol we use less and less. Darvon is no longer used, but it's out there in some places overseas. Percocet, something called Lomotil. Lomotil is an antidiarrhea agent, but it has narcotic effects. Fentanyl we hear about all the time, Vicodin, and wild nil. Wild nil is a narcotic they used if they had to sedate a water buffalo or shoot a tiger or shoot a bear in somebody's backyard. They would shoot it with wild nil, which is a very potent narcotic. They cause simple symptoms that we're all aware of: CNS depression, slowed respirations. This is probably why most people die. Respiratory arrest, seizures, pinpoint pupils. Sometimes people get excited. hypoxemia, hypothermia, and sometimes you have to look for other effects. What did they mix with that? Like a speedball and cocaine is heroin and cocaine mixed together. Don't try these at home, packing them in ice, pouring milk down the victim's throat, injecting milk IV or IM, believe it or not, I've seen it. Injecting coffee IV, not a good idea. Or the old Pulp Fiction needle to the chest type of thing, which is Hollywood. Naloxone or Narcan we use every day. Our police officers now carry it and will sometimes give it before you even get there. 2 milligrams IV, IM, sub-Q or nasally, and you can repeat it. You can see acute withdrawal reactions with this. So I have had people who are overdosed on Narcan, overdose on narcotic. I give them Narcan and then they immediately go into withdrawal. Sometimes crying, begging, screaming, and hysteria. Usually it wears off pretty quickly, so you have to be careful. Treating once is not enough. So if you give Narcan, don't give Narcan and leave. You should transport that person to the hospital because sometimes the Narcan wears off in an hour and that person can be right back into respiratory distress. Care is also supportive. Sometimes oxygen is necessary, ABCs. Sometimes you have to intubate, especially if Narcan's not working. Sometimes you have to sedate them after you give them Narcan. And very often in a coma cocktail, we'll give a patient Narcan, dextrose, and thiamine, although thiamine is falling out of favor. And it's kind of in there because a coma cocktail will treat the major things. Thiamine for alcohol problems, dextrose for people who are hypoglycemic, and Narcan for narcotics. I think this is our last topic is the sympathomimetic. Sympathomimetics are your fight or flight drugs. Adrenaline is the most common sympathomimetic. That's the legend of a 90-pound person lifting a car off a trapped victim due to adrenaline. Sympathomimetic syndromes are characterized by excess stimulation. There are legitimate and illicit drugs can cause this syndrome. Here are some of the drugs that we talk about: cocaine, amphetamine, and methamphetamine. Keep in mind that cocaine is illegal unless you're using it in an ear, nose, and throat doctor's office. Amphetamine is commonly prescribed for people who have ADD. So Adderall and things like that are a form of amphetamine. Methamphetamine, of course, is illegal. Phentermine is a weight loss drug. Aminophylline is not used very much anymore, but you can still see it in some people and it's used for treating asthma. Dopamine, epinephrine, caffeine in excess can cause this. Ephedrine, we don't see it as much, but in China, they still produce it over the counter and they sell it to truck drivers. We used to see a lot of this in truck drivers. Ritalin, which is a form of amphetamine, is also used to treat ADD and ADHD. And Sudafed in high quantities can also cause this. And keep in mind that Sudafed in the state of Oregon and many states, you need a prescription or you're only allowed to buy one box. That's because somebody with a basic knowledge of chemistry can use Sudafed and a couple of the things and make methamphetamine. That's why Sudafed has become so restricted. The manifestations: stimulation, seizures, sweaty skin, paranoia, sleep deprivation. Think of your common people we say are tweaking. Tweaking or methamphetamine can cause this. Psychosis, people can be crazy. They can get excited. Tachycardia, anxiety, visions and hallucinations. I think every drug we talked about today has caused some form of hallucinations. Odd behavior, hyperthermia. Treatment, usually supportive. Closely monitor their vital signs, ABCs, sometimes put them in a quiet room or try and quiet them as much as possible. When we get them in the ER, we put them on a monitor, we'll darken the room, treat them with some benzos usually, make sure that they don't have a seizure, and rule out other causes, because that's done in the emergency department, right? They might be crazy for some other reason. They might have a head bleed. They might have sepsis. They might have meningitis. Usually family support in a quiet room. You can see this. This is a picture from years ago when I was working in Philadelphia. We had a guy who was a mule, and he came in because he was packing cocaine. He was a mule, and these are all condoms full of cocaine, and one of them exploded, and he died in the operating room. And lastly, withdrawal. Just like any drug, if you use it all the time, you might get used to it. So not taking the drug can also cause a toxidrome from withdrawal. A great number of patients are addicted to medications or take them every day, whether it's alcohol or Xanax or Ativan or Valium or something like that, or a narcotic. And withdrawal can lead to side effects and sometimes confusing symptoms. Alcohol, cocaine, narcotics, opioids, barbiturates, benzodiazepines like Valium, amphetamines and methamphetamines that I talked about, either legitimate or non-legitimate, and paraldehyde is relatively rare, but it's out there. You can get seizures, hypertension, muscle cramps. There's our friend hallucinations again. Hallucinations here are a little bit different. These are what we call, they used to be called the rum fits. And these are what somebody else might consider, you know, the elephant, the crazy elephant, or hearing voices, or seeing snakes. These are all possibilities. There's our friend lacrimation and sweating again is a little bit different. Usually we'll see this as a manifestation of a seizure. Somebody has a seizure and we know that they haven't had enough alcohol that day. Somebody tries to quit alcohol and go cold turkey. Very often they might have a seizure as their presenting symptom. They can get combative. Piloerection, that's not a dirty word, it just means goosebumps, insomnia, restlessness, weeping and pleading, crying, and emotional distress. Again, treatment, mostly supportive. Try and be kind and understanding to these people. Sometimes it's very difficult because the patients could be very difficult. Avoid overstimulation. Sometimes sedation might be needed. We might need to give thiamine if we suspect alcohol withdrawal. We just took thiamine out of, I think I talked about this in one of our recent lectures. We just recently took thiamine out of our protocols, but it's still something that we would give in the emergency department. If they have a seizure, give them benzos and make sure you treat their glucose because you don't want to miss hypoglycemia. All right, so this says, Mr. Osborne may be excused, my brain is full. So I'm sure you're all feeling that way. We went over a lot of symptoms, a lot of quickly. So if you have a question, you can unmute one at a time. No questions?
Well, okay, so for most of these, we are treating the symptoms instead of the direct cause, correct?
All right, sorry, you're gonna have to repeat that. I'm gonna go ahead one more time.
So we would treat the symptoms instead of the direct cause? Because, I mean, minus like the terrorist attacks and stuff like that, we we don't really know what's causing it.
Right.
Or we don't know what's causing them to seize or what's causing them to be unconscious, but we can treat the symptoms. We just can't treat the cause.
Yeah. Well, here's the hard thing, and this is what I said at the beginning. You're perfectly right. You're treating the symptoms, but if you step back and take a look, sometimes you will see a pattern. So that's why I pointed out why confusion sometimes is in almost all of these. Well, that doesn't help us a lot. But if we start to look at some of the big symptoms, we talked about the anticholinergic symptoms, right? We start to say mad as a hatter, dry as a bone. And then we do a little detective work and find out, well, she could be septic, but one of the things that we try and do is look at what else could be going on. Very often, you guys will bring us a bag full of medication. And I'll say to the paramedic, well, what's in there? Oh, I don't know, a bag of medicine. And I'll say, well, look at them. Tell me, what do you think? I don't expect you to be a physician. I don't expect you to be a pharmacist. But if you look through some of them, you might say, oh, this person's acting really strange, and here they are on Haldol. Maybe they have schizophrenia, and now they can't talk, and they're all twisty, and they can't talk right. And then you contact medical control, and you tell me that, and I'm going to say, oh, give some Benadryl. So yeah, most of the time we are treating symptoms, but if we look at these symptoms together, we look at the big picture, we're going to start saying, oh, I recognize that syndrome, or I recognize the syndrome of the sludge syndrome. I'm going to recognize that this might be something that is a pharmacology thing that happens with a poisoning or an overdose. Or, you don't have to be a rocket scientist. If you get there and they're not breathing and you find a needle in their arm, that they're going to need Narcan. So yes, you're going to treat the symptoms, but what I'm challenging you to do is think what else could be going on. That's a long answer to a short question.
So kind of like pattern recognition, where you run on the same, or where you recognizing like someone that is, well, I'm gonna use overdose since you used that one. Pinpoint pupils, the slow breathing or not breathing.
Right.
Go down, and then you go straight to the Narcan instead of other routes.
Right, exactly. And again, when you weigh everything is harm versus good treatment, Narcan really never hurt anybody, except for getting rid of somebody's high they just paid for. So really, I've given Narcan, and I've had people look at me and say, why did you do that? You just ruined my high. Honest, I've had that response. Well, it's kind of, you were dying, so I gave it to you, and I'm sorry that I ruined your high. But, if you're called to a farm, like I said here, and the guy's drowning in their own secretions, you better get the atropine out, right? Or if you're this guy and you're in a warfare and now all of a sudden you can't breathe, you're going to inject yourself with the 2 pens that are on your arm. So recognition of pattern, you said the correct word, pattern recognition. You're going to see these syndromes, and I want you to start thinking of poisoning as a syndrome.
All righty, folks. Good questions. Anything else?
When you were talking about things not to do for Narcan or for opiate overdose patients, one of the things you had mentioned was not giving coffee IV. But then that made me think back. I've heard of giving IV caffeine to neonatal abstinence syndrome babies.
Well, we used to give neonatal.
Abstinence syndrome. So
Okay,
important to moms that are, abusers.
right. That may be something that's done in a NICU. We used to use, this was actually before my time, but when I started out, I was a nurse's aide before I went to medical school. And I worked in the ER. They used to give IV caffeine, not really coffee, but IV caffeine to people who came in drunk. They still make caffeine IV, but it's very, very rare that I would even see it. I think it's been, like I said, greater than my career, so probably greater than 30 years ago that they used caffeine. But I have seen in this slide all of these things done where, people are, and I had a scene I took out here that used to be from the Pulp Fiction where she had a overdose. She thought she was snorting cocaine and she wound up snorting heroin, and John Travolta winds up giving her a caffeine in her heart, adrenaline in her heart. It's very, very Pulp Fiction, very Hollywood, but it's not something that you would do. As far as doing the treatment of caffeine in the neonatal intensive care, I can't speak to that. I don't take care of those kids, but it's possible. I have a question for Jane. Did you get your power back?
I did. I managed to stay here right before it was in the red, and right before it popped completely off on my computer, the power came back on.
How lucky are you?
Yep. All right. So here it is at 8:15. Thank you, Dr. Eschelbach, for a wonderful lecture again. Folks, give me a few days. As long as this video transfers okay, then I should post it in the MD Roundtable blog inside the course.
Hey, Casey has a question sheet that he typed up.
Casey, if during a cardiac arrest there are signs of opioid overdose, would Narcan be something to consider besides the normal code drugs? Yes.
Yeah, and the answer is yes. Yeah. You especially when you get into, let's say, your PEA rhythm, there's all kinds of things that you're supposed to consider. Your 5 T's and your 5 H's. But yeah, if you've got somebody who you think and you suspect is a narcotic overdose, I would, if you have a high suspicion, I wouldn't give Narcan in every cardiac arrest. But if you've got a young patient, think of the syndrome, think of the situation in front of you. Is it a possibility? That's where you want to be the detective. Before you call a code, look around the room, is there something else I could find? Do I find an empty bottle? Is this a suicide attempt? Is this something else? So I wouldn't put it in your normal armamentarium for advanced cardiac life support. However, if you're being a good detective and you suspect it, Narcan could help.
And I think, Casey, when you take your ACLS class before you finish up paramedic, you're going to find that is definitely in the algorithms to assess if there's any treatable causes like Dr. Eschelbach mentioned. And if there's something that you can treat that may be contributing to the arrest, treat it. You may actually get lucky.
It reminds me of a call that we went on for a adult female unresponsive. We get there and fire gets there and we're walk in and she's laying in the bed. Husband had been watching her since 6 o'clock that morning, just get worse and worse and worse. And this is like 2 o'clock in the afternoon. And we slapped the pads on her, or slapped the electrodes on her and everything, and her heart rate's like 50s, and just crappy rhythm, everything. And they're getting ready to intubate her because she ain't breathing very, very well either. And they and they weren't able to get a tube, so they drop a kink, and we're rolling her out the door, and the other crew shows up and is like, "Hey, did y'all push Narcan?" It's like, "No." I was like, "Well, we ran on her about a month ago for a overdose." I was like, "Well, we already got our own drugs on board, so we'll tell the hospital." We transported to the hospital, and we got to the hospital, and they walked in there and they pushed Narcan and woke her right up, and she was mad, but she's alive.
There you go. Yep, you ruined my high.
All right, everybody. Thank y'all very much for tonight. Dr. Eschelbach, we'll be talking soon.
All right, thanks. Take
Thank
care,
you
James.
all.
Good night, everybody.